with multiple groups within NCI that are known to do the kind of work that Dr. Sudha and Dr. Preeta were talking about. So there's a whole center of cancer epidemiology and genetics. There are other groups that do multidisciplinary joint work, and I'll show you some of our data so that you have an idea of what we have. The data is drawn from multiple centers. Right now we are operative in 5 Apollos. We have data for about 3,300 breast cancer cases, and we expect to cross 10,000 before the year is out. Can we partner with NCI proteomics and genomic projects? Because again, there's no point in sitting in India and not being able to participate in collaborative networks like the ECOG. Last year, there was data published from 16 countries as part of a breast cancer cooperative. There wasn't a single Indian data point. Can we create an Indian reference genome for breast cancer? An Indian proteome for breast cancer? Whether the work is done here or whether the samples have to go out doesn't matter, but can we share this resource? We're working on some of the prognostic markers that I'll show you a little bit about. NCI and NIH fund spore labs that then become the anchors for dealing with a large number of labs that test new diagnostics. Can we pilot those in India before they are launched? And basically, we've set up some cell-based models that are looking at cancer stem cells, which I will share with you. NCI again has a very rich database of tool compounds like siRNA, shRNA, modulators, compounds. Can we screen them in our platforms? One of the things that NCI had done a long time ago is to set up ATCC as a repository of cell lines. Anybody who's worked in biology would have used some or the other cell line of ATCC. We have the capability of setting up Indian cell lines with novel BRCA mutations, for example, that somebody was talking about earlier. We have so many. Dr. Rajiv Sareen was talking about unknown variants. There are a number of hotspot mutations in India. We can create India-specific lines. So I'll go through some of our data to showcase what we can do in these areas, and we can come back and discuss them at the very end. So epidemiology and outcomes. My talk will be like an abbreviated version of what Dr. Selvi just presented. I'll go through it fast. So we have collected data from many different Apollos. And in fact, Chennai is one of the largest centers. That orange one, 1905, is coming from Chennai. So it's entirely possible some of the data that Dr. Selvi was talking about is also included here. Hyderabad, where we are based, is the next, where we've collected pretty much the entire set. And on the right side, you'll see in that table the year of diagnosis. So we haven't taken some of the most recent patients that were diagnosed because we were trying to collect 5-year outcomes history. So Chennai has been storing samples as early as 1998, 1997, and there are gaps in there. So this is work in progress. So this is data that is drawn from about 3,300 patients, and about 2,000 more is in the process of retrieval. We expect to get to about 10,000 by the time more happens. And again, you may not be able to see from there because I know these roses are obstructing it. We have some very interesting cohorts. Just like Dr. Rajiv Sareen was talking about, we have bilateral breast cancers, some synchronous, some metachronous. Can we look at those? We have male breast cancers. We have some that have original tumors as well as recurred tumors, if you want to look at drivers and how they have changed. It would be nice to get together within the country to increase that cohort and derive some meaningful data from them that then impact at least future patients to have better outcomes. This is an age-wise distribution. Like Dr. Selvi just said, majority of the patients are in that older bracket of 41 to 70, but about 17% cases are women who are less than 40 years. Clearly, some genetic counseling and family history is warranted. This is the median age at diagnosis, rather similar across various centers. And if you look at the red dots, those are the minimum age at which the first case has been shown. So quite a few very young patients across these areas. The median age, however, of about 52 is common across the 5 centers. And this is where the data you start to see, this is historic data, remember, starting from 1998. So when you come to ER/PR HER2, it's still not standard of care to get all 3 tested in India. And particularly for HER2, maybe because the drug didn't come to India till about 2012, testing was not done. So more than 50% of our samples that we have collected data, we don't have HER2 data at all. Even today, either the data is not available, patients don't even get tested because they may not be able to afford the treatment. However, treatment of triple negative breast cancer is different from HER2 positive. So even if a patient will not be able to afford Herceptin, it is imperative for the doctors to want to tell the patient that we should know whether you're triple negative or you are HER2 positive. Of the patients, the data was available. ER/PR positive, very similar to what Dr. Selvi was saying, runs at about 60%. However, HER2 positive, the 2 groups combined, is closer to 40%. And this is what I've heard from some of the pathologists in Bombay as well. Triple negative, very similar to her data as well, is about 20%. However, there are quite a few regional differences in triple negative frequency. And this is mirrored by the publications that are also all over the place. So if you look on the right side for a minute, the reported incidence from outside India, Caucasians running at 12 to 18, African Americans 22 to 28, Latin Americans apparently are also at higher risk, African running at 35 to 50%, and then the Indian data varies enormously in publications. There are papers from TMH, from Rajasthan, from Assam, and again, the range is from 12% to 32%. Our own data shows center-wise differences, with Hyderabad leading at almost 30%. Whereas in blue and in green, you can see Delhi and Kolkata significantly lower. So this effect of perhaps consanguineous marriages or cultural differences or community differences, this is quite real. We have large numbers of patients. This should be looked at. Now I'm going to speak only specifically about TNBC for a little bit because we are focusing a lot on it. This is a hard to treat disease. There's no targeted therapy available. So we're doing a deeper dive into it. So of the TNBC cases, the median age is similar, again, except for Hyderabad where you see a little bit of a dip. In general, the median age at diagnosis is not much different than normal breast cancer. And yet, there are papers that talk about triple negative hitting even a decade earlier in India. We're not seeing that. Whether it's a corporate setting, we don't know. This may not be applicable to rural India. Choice of surgery, very similar to what Dr. Selvi just said. MRM seems to be the choice of surgery. There's a little less usage of it in early stages. However, it seems to be very surgeon-specific is also something that we notice across the centers. Maybe it is just being conservative of not leaving anything to chance and just doing mastectomies. Choice of chemotherapy, again, anthracyclines alone are not used in later stages, definitely used quite a bit in earlier stages, but as you go up in stage, anthracycline followed by taxanes is quite common for patients. And then this one, which I just skipped over, is the outcomes data. We didn't have sufficient number of patients in triple negative breast cancer for which we had 5-year outcomes. So this is limited to a very small number, and I would not draw too many conclusions from it because many patients are lost to follow-up because we're talking of patients that were diagnosed back in 97, 98. However, what is heartening to see is that the 3-year survival was running at about 74%, which is similar to the 80% that is reported globally. We do need more data, so all the people that I heard today speaking, be sure I'll be coming to you to see if we can work together. So this data that I was speaking to you is mostly to ground us into understanding where should we be developing more prognostic markers. So now I'm going to talk about two sets of prognostic markers that we are developing. One is how do we predict response to therapy? And the second is how do we better predict risk of recurrence? So there's an emerging field, particularly in triple-negative breast cancer and in HER2-positive cancers, where tumor-infiltrating lymphocytes are becoming a gauge to see whether the person will respond to chemotherapy or not. And this cartoon is just to show on the left side, this is when our T cells and B cells and host immune cells are still trying to fight the cancer. And over a period of time, the cancer overtakes it and the cells are co-opted. So in this case, what we have done is using our samples, also started to analyze, again in triple-negative breast cancer, what is the percentage of tumor-infiltrating lymphocytes. And what is interesting to see, again, it's a small number of patients that we've done so far. This is preliminary data with 85 triple-negative breast cancers. Every single event, so there are 5 recurrences and 6 deaths. Recurrence is in blue, red is death. Every single one of them, 11 out of 85, are all where the TILs were less than 7%. So this is before they took chemotherapy. This is the surgical sample. So how can we improve upon it? And particularly if you look at percentage of TILs over the survival time, you start to see a trend. I wouldn't call it statistically significant yet, but if you just focus on the green line, which is stage 3, there's a clear trend towards increasing TILs predicting response over a period of time. Similarly, we're working with a Bangalore-based company that is trying to improve upon Oncotype DX and MammaPrint, where they're even including lymph node positive early stage breast cancers, which would be HER2 negative as well. And this data set is performing really well. We are expecting to launch this test in May or June of this year across Apollos. The last thing I'll talk about briefly is that we've created panels of primary tumors, and we use them to screen for known drugs to then identify resistant cancers that can be used to screen novel drug candidates that would still work in cells that have become resistant to chemotherapy. And so on the right-hand side, you can see, for example, that red curve, the same cells, that is SB408, that is not responding at all to cisplatin, does respond to doxorubicin, shown on the left side. So we're creating cell panels in which to test new drugs. And in trying to do so, what we've also done is created a model which is called EMT, where we've taken completely normal breast epithelial cells from breast reduction surgeries and sequentially transformed them using known cancer genes into metastatic triple-negative breast cancer in our own labs. And what that does is, I'll just go through. On the left-hand side, on the top left, you'll see normal epithelial cells. They're not able to grow in colonies. They need a lot of nutrients to keep them growing over a period of time. On the bottom right are the triple-negative breast cancers that we have generated from similar cells as are shown on the left side. These form colonies. They don't need to attach to plastic. They don't need serum. They can migrate. They can invade. And those kinds of cells are called EMT, epithelial to mesenchymal transition has already happened. These cells form mammospheres. So these three-dimensional cultures are called mammospheres. They're spheres and they're three-dimensional. They mimic in vivo growth much better. And what is very exciting is you see a huge upregulation of cancer stem cells by this process. So these become platforms by which we can screen for targets and molecules that can go after cancer stem cells. So I come back to basically talk about whether there are ways for us to collaborate internally, externally, to use these kinds of platforms and capabilities to really impact our future breast cancer patients. Thank you.
Thank you, ma'am. Next on stage, we have Dr. Ramesh Nimagada, who started his career as a medical oncologist in Canada in 1979. Dr. Ramesh has been with Apollo Hospital since 1985 and is currently the Director of Medical Oncology. He developed and ensured implementation of OncoCollect, a data collection software for oncology. He's also the managing trustee of Ramesh Nimagara Cancer Foundation. Sir will now be telling us about the way forward.
Thank you. Good afternoon. I think we are getting into the evening actually. One more hour plus to go after me. I'll try to finish a bit faster. Can I have the first slide, please? The real world data is probably the one that we need to keep going, at least in this country. I have no doubt in my mind at present time. And as I see this one slide, this is Professor Cunningham from UK Marsden. And he said quite rightly that extrapolating results from clinical trials for each patient are often highly selected for age and other parameters. Maybe to clinical practice can be very challenging and sometimes very restrictive. And that becomes quite often we face this, and evaluating and hopefully confirming the safety and the potential benefits of new therapeutic options in real-world clinical practice bridges this important gap in our knowledge for the benefit of patients. And now this is Dr. Cunningham saying that the studies we do they really apply to the clinic patients in the same population? And when I came back from Canada in '85 and started treating, and also we built this hospital in '93, the first cancer hospital in Apollo chain in Chennai in '93, we started this. And that time when I was treating patients, I realized that we often have to modify doses or the schedules, delay treatment, several things for the toxicity. And then I started thinking that we have to collect our own data, because unless we look at it, we will never know whether it is really the disease or the patient, and what is happening to the patient when we are doing all these modifications. So I started collecting data in '99, and that is when I started getting interested in actually developing a software for myself personally to collect this data and analyze. And then we did that from '99 to 2008. I will present the breast cancer data that I had very quickly. And this is, as you can see in the top left, the breast cancer staging. And in being a corporate hospital, between 1 to 3A, we had about 80% of patients, and mostly 2A and 2B. And again, when you look at the next set of patient graph, the right top, and there it is the first 5 years of the 10 years, the lymph nodes were about 60%, and in the next 5 years it has come down. So obviously there is a little more earlier presentation of the patient. And we look at the left bottom, you can see that taxanes we started using somewhere around 2003, and slowly initially with the lymph node positive disease, and subsequently by 2008 we are using practically in every patient. Essentially we use FECD basically to reduce the anthracycline toxicity. So all these patients still do get the anthracycline apart from taxane. And then when you look at the follow-up after these patients subsequently, this slide is about 1.5 year old, but at present we have about 90-month median follow-up of these patients, about 420 patients, and all from stage 1 to 3A. We only took up to that. We didn't take 3B, 3C, 4, and we had about 10%, 14% last follow-up, but out of that, 5% after 5 years. So we had 90% minimum 5-year follow-up. With that, we had a survival of this, as you can see, beyond 10 years, 12, 15 years now. And the stage 1, we had only 57 patients, but about 95% at 10 plus years, and there is really no relapses after. And stage 2A, a good number of patients, 151, and continue to have about 90% relapse-free survival at about 10 years, and so on and so forth. And these are comparable with the modifications of doses or schedules we had to make with these patients. Now, the other thing, important thing is over this 10-year period, 1999 to 2008, we had different regimens that has come and gone and all, and so we kept modifying and changing to see which one suits well for us. So basically, every one of them had some anthracycline, and couple of regimes had docetaxel added to that. But when we look at it, at the end of it, actually, to me, as you can see grossly, there is maybe 2-3% difference, and I'm sure stage-wise, if we look at it, it may not be very much more. So this is important to me, because if I can find that there is a drug regime that can very easily given anywhere in a simple setup, in any community hospital, in a smaller town, with no risk or safe, with good safety, and makes only 2 or 3% difference than the best I can give. And that is probably what we should be doing across the country. And we'll come to that. This, I think, is very, very important, because we need to know what is the lower level at which has some effect, and what is the higher level beyond which it is more toxic than no effect. Because until now, we only have what we call maximum tolerated dose, or MTD. We never really know what is the maximum effective dose, or rather the minimum effective dose. Both of them, we really do not know in literature. Next slide. And next slide. Then we looked at the 5-year periods, both the 5-year periods, and the top one is the second half, 04 to 08. And that did better, maybe because of the lower axillary node presentation, incidence, as well as some taxane usage as well. Next slide. Oops. Now, I want to show you a couple of things about this minimum treatment and maximum treatment. And this is Kedwai Institute in Bangalore. And they presented the study on lung cancer, non-small cell lung cancer, stage 4. And as you can see, in the first 3 regimens are pretty standard regimens across the world. And the last regimen is something they have used. Before they started using the last regimen, the patients who could not afford the first 3, they did not treat them at all. And they found the median survival for them is about 3 to 4 months. And then they found the last regime they could get for about 500 rupees. That's about less than $10. And so they started using that. And as you can see, the median survival is about 2-month difference, 9 months to 7 months. But at the same time, double what the no treatment gave. So obviously, the last regime does help, maybe a little less, but not a lot less, and certainly more than no treatment. So that's what needs to be done. And if you look at this now, ASCO has published this in JCO, as you are all aware of it, and we can see pemetrexed and cisplatin is supposed to be the better one than gemcitabine cisplatin, and the cost is so much different. The last one, everything else is equal in the earlier clinical benefit. Toxicity cost is 10 times what it is. So again, this is another study with trastuzumab for 12 months versus 6 months, French study, and then they found that the difference is about 3%, and this was not felt to be equal. And so for this reason, this study was felt to be a negative study. But one need to look at it a little more closely in this one. We look at the difference that is about 4 years, and that is about 3% difference between the 2 arms.